I put together a few things. The first caveat is I'm not a pulmonologist. Okay, I'm a pediatric hematologist, oncologist, geneticist, all things telomeres person. But I put together some stuff about lungs and lung function and lung disease. And then I thought since we've been talking already with Dr. Myers, and then in the next session, we're going to talk about clinical trials. And I thought it might be helpful to just do some definition. Just what is a trial and what does that mean? So that's what we're going to talk about too. So this is actually a really nice YouTube video. I thought I'd share it, but just in the interest of time, we won't. But if you go to lung.org, the American Lung Association has this really nice video on YouTube. It's about 2.5, 3 minutes that basically explains how lungs work. So how I think of like the lungs and the heart is really as a pumping system. It's almost kind of like your HVAC in your house, where you have air coming in, you have things moving around through the lungs, getting oxygenated, blood getting pumped back out, blood coming back in, coming back out through the lungs, and blood being kind of pushed around. So if you think about it that way, it's complicated, but it's actually not quite as complicated. And this is I just wanted to just put this up here. This is a normal chest X-ray. Many of you have probably seen these. This is the heart in the middle, the vertebra, the ribs. This is your clavicle, and so this is what kind of our baseline looks like. And this is just a picture. And again, I'll have all these slides available because I have a ton of info here. Heart, all the blood vessels, the trachea, the lungs. Okay. And that's just important as baseline to sort of think what we're going to talk about. Because you need to understand what's normal before we can understand what's a problem. So a lot of you have also done or will be doing PFTs, pulmonary function tests. Now there's a lot of measures on those reports, and people like me have a hard time reading them because they're really complicated. In general, pulmonary function tests measure kind of how good you breathe in, how much air you can breathe out. They measure how good your lungs are at exchanging gas, right? So our lungs, the goal of our lungs is they take in air, they take in the oxygen. They have to send it all around them to oxygenate the blood. And then that oxygenated blood gets collected, goes to the heart, and then gets pumped out. So the lung PFTs, there's a bunch of different measures, but they basically think of it as they measure how much air your lungs can take in, how much they can push out, which is a measure of sort of the flexibility of the lungs, and then how good are they at moving oxygen around where it needs to go, okay? The 6-minute walk test is also one that's done, where many of you have done it. I'm sure you walk up and down the hallway for 6 minutes, you have this pulse oximeter on your finger, and you see how basically how good you are with exercise. Okay, I'm just going to touch on this briefly. This is something that we see more often in our younger patients who have TBDs, are something called pulmonary arteriovenous malformations. So like so many words, it's a really big word, it's a complicated idea. But if we think of the fact that our lungs and heart are basically kind of a two-way street, right? So the whole goal of our lungs is to oxygenate our blood. And that means that you have sort of two systems where you take oxygenated blood, you push it out to the body, you bring up that deoxygenated, that's our veins, you bring that back to the lungs to get more oxygen and push it back out. The problem with the pulmonary arteriovenous malformations is that there's an abnormal connection between the oxygen-rich arteries and the oxygen-poor veins. Normally they're separated and our lungs kind of reinfuse our veins with oxygen as we move forward. So in a PAVM, there is a problem because the oxygen-rich blood is getting kind of contaminated by the oxygen-poor blood. So instead of having normal oxygen flow around your body, when in your blood, you have this what's called a shunt, and that can cause symptoms, and it's often can be related to liver disease and hepatopulmonary syndrome. There's a whole other host of problems. We've also seen this in some of the subtypes that I think Dr. Uchuch is going to touch on after lunch. This is just a picture of what I was explaining. So this is what our capillary bed. So the oxygen poor is always shown in blue, oxygen rich is in red, and this is a normal connection. Okay, this is the abnormal connections in an AVM. And this is just another way to look at that same thing. So you could see normally there's this connection that our oxygen is moving in our lungs, and if things are kind of all mixed up, the plumbing isn't working right, that's when you can have an oxygen problem. Okay, so now I'm going to switch. We're going to talk a little bit about pulmonary fibrosis and lungs. So this is another way to look at our lungs, and these are the alveoli. This is like those little breathing, the little sacs that have the air. So we bring the air in. You have the blood vessels that surround them, and that's where this diffusion happens. So normally our alveoli are these little sacs that are really great at exchanging air. When we have pulmonary fibrosis, a lot of times what happens is those alveoli get thickened and get stiff. Your lungs get stiff, and you could imagine if you have something that's normally really flexible and flowing, and now it's thick and stiff, it can't exchange air as well. This is another way to kind of look at it, where you can see normal alveoli, they're thin, they're flexible, the capillaries, the blood vessels are able to kind of exchange the blood and get oxygenated. With pulmonary fibrosis, the gas exchange just can't work as well because instead of being sort of thin and flexible, it gets thick and stiff. Okay. And this is, I like this when I found this, this is a CT, a CAT scan. And what it actually shows in one image is lots of different features that the radiologists and the pulmonologists are looking at. You can see the normal lung it actually looks dark here, and that's because it has air in it. Right? This is the chest wall, this is the heart, these are blood vessels of the heart, this is kind of the back, and your vertebrae, ribs are wider. And you can see normal lung, this reticulation pattern that some people may have heard about. And then honeycomb changes. You see there's more white stuff here. Bronchiectasis is another word for kind of collapsing of those alveoli. So what you can see is in people who have pulmonary fibrosis, basically there's more white stuff in where it should be black with the air. And this is an example of a patient of mine who has pulmonary fibrosis, and at 54 years, and then at 57, you can see the progression. You see all the extra, white marks in the lungs. And the image on the left side, the right side rather, is fibrosis. So that's a microscopic image where instead of having those big loopy kind of alveoli that can move gas around, all that like yellowish, greenish is fibrosis. So there's a lot of causes of pulmonary fibrosis. We're not going to go into all the details. Many of you have had to deal with this. In the TBDs, we know that there's the underlying biology is the problem, right? We talked about genetics yesterday and changes in those genes. And what we think is happening in the TBDs is sort of a lack of the lung stem cells. We talk a lot about blood stem cells with bone marrow transplant. This is in the context of having lung cells that can regenerate. They can't regenerate well. Maybe they get stiff and scarred. And there's a lot we don't know about pulmonary fibrosis. And when you talk to pulmonologists, the actual biologic mechanisms are something that people are really still trying to understand. So I'm just going to, again, at a very high level, talk about how do we treat pulmonary fibrosis, focusing on what we know from the published scientific data, okay, as far as treating pulmonary fibrosis. There are a lot of studies. So a good chunk of pulmonary fibrosis in the general population is actually related to inflammation. So people can have this huge reaction to a stimulus like an infection or an environmental trigger and have massive inflammation. And that's a type of pulmonary fibrosis that in the general population develops. Those often respond to anti-inflammatories. This was a study that looked at people with and without, they basically looked at people who had pulmonary fibrosis in general, okay? They hadn't specific targeted TBDs yet. And then they said, well, who got immunosuppression, which would be an anti-inflammatory treatment, and how did they do and what happened? They also measured the telomere lengths in these patients. Now, they weren't diagnosed with a TBD, but they would had telomere lengths measured, okay? To make a really long story short, people who had telomeres less than the 10th percentile for their age and who got the anti-inflammatory immunosuppressive therapy did not do well, and in fact, they did worse. And if you think about it, it kind of makes sense because the biology, the cause of that pulmonary fibrosis is probably different in people with short telomeres than those who do not have short. So another study, there's been a lot of new exciting work over the last really decade looking at anti-fibrotic medications. I've talked with some of you about those and whether they can help people with TBDs. Again, in people with general, what we call idiopathic pulmonary fibrosis or immune-mediated pulmonary fibrosis, we know that antifibrotics can sometimes help. They can extend life. They often have a ton of side effects that actually make quality of life not as good as you would like. So this was one study that looked at just a small number a relatively small number of patients with TBDs, and based on their gene. And they found that these antifibrotic medications might marginally improve lung function. So that's a good thing. But there really still weren't enough data to show. These are looking at two different drugs, pirfenidone and nintedanib, and they looked to see how patients who had a TBD were treated and if their lung functions were improved. And there's a suggestion that maybe they help. But again, the numbers are small. The data need much more studies. Another study that we've talked about a lot, we haven't, that Dr. Olson mentioned, is about danazol. So danazol is an oral androgen, which is a male hormone. Okay, as he said, they used for huge baseball scandal, 15, 20 years ago, and danazol is an attenuated androgen, meaning it doesn't have as many side effects as some of the other types. We know very well that people who have a TBD and bone marrow failure, about 70% of them will have a bone marrow improvement on danazol. And we sort of see that as a bridge to transplant. Some patients, it can work long-term for a long time. Others, they need to go to transplant sooner. One of the questions that's really still out there is, do these androgens help with lung function or some of the other complications we see in TBDs? This was the first study that looked at danazol in patients with TBDs and asked, does it extend telomere lengths? And does it improve lung function? So this study showed that they did see small increases in telomere length when people were on danazol, and those lengths declined when they stopped it. There was a small suggestion, maybe lung function improved, but again, the numbers were really small. And I also learned from my pulmonology colleagues that quantifying lung function is really difficult. So if you have a diffusion capacity of 65% today and it's 70% next year, but the following year it's 61%, it's probably all the same. So those numbers are really hard to also use as sort of data to get at them. There is another low-dose danazol trial that's going on at the NIH. And if anyone wants more information, I'm not running it. It's Dr. Neil Young's group. I'm happy to talk with folks about that. So a couple things about familial pulmonary fibrosis, and just again, all this is going to be. I'm going to share these slides. There's a lot of info here. The European Respiratory Society recently put out a statement on familial pulmonary fibrosis, and I just thought y'all would like to know that these different international groups are really focusing in on how to best treat patients with TBDs. Okay, and so they have recommendations, and you can even see they assess all the different genes. They have different, they define the features, and they're suggesting that antifibrotics might be considered. Again, I would prefer that people do that in the context of a clinical trial, because that's how we're going to learn the most for everyone long term. Another paper that was just published last year is a roadmap to precision treatments for familial pulmonary fibrosis. So the TBDs are just one of several different causes of familial pulmonary fibrosis. So the lung doctors out there are really coming together on how to better treat things. And this is very busy, but it actually bridges into what I want to just touch on now is clinical research and clinical trials. And this is their recommendations, which basically say more research, more clinical trials. So we talked a little bit yesterday and today about clinical research, and I want to just go through some definitions. So clinical research can be patient-oriented, so it can be a drug trial, it can be a behavior intervention trial. It can also include epidemiology and behavioral studies and outcomes research. This is our approach. So my expertise is really in long-term natural history studies. I work with epidemiologists, with clinical researchers, and our approach is to study the whole family, where we have our participants, we do lots of questionnaires, we do evaluate people with their home docs, some of the patients we bring to the NIH. So that's kind of a natural history study where basically you enroll people, you follow them for as long as you possibly can, because you really want to learn as much as you can about what's going on. Ideally, you can also study their family members, because then you get a sense of what's part of having one of those rare diseases and what's just part of being a member of that family. So, and actually going back to that, I talked to several of you yesterday about our natural history study, and if you want more information, come see me. I have some additional paperwork and stuff. So what's a clinical, that's kind of clinical research. What's a clinical trial? So the official definition from NIH is a research study in which one or more human subjects are prospectively assigned. Prospectively means you start today and you follow tomorrow, the next day, the next. That intervention could be a drug or a placebo, and the idea is to evaluate those effects on medical or health-related behavioral outcomes. There's more definitions here, which we don't need to go into. There are really kind of 4 phases of clinical trials. This just puts it all together. We talk about preclinical, so that's lab-based work. Often we talk about stuff in culture, mouse models, that sort of thing. Safety and dosing, safety and efficacy, which means how good it works, and then post-approval evaluation. So what do all those mean? So a phase 1 study is often what I think of as first in human, might not be first in human, but it can be. And it really tests whether the drug you're interested in this case, is safe to give to people. What are the side effects? What is the dose range? Okay. And it's usually very small. It's usually, here we have 20 to 80. I've seen them done even in smaller numbers. So it's really the first time you're giving a drug to a person and you want to understand its safety profile. Is it safe to give? Do our biomarkers, do our blood tests make the changes that we think they should based on the biology? The next step is a phase 2 study, which tests whether it has a treatment on an effect on the disease. So I just want to emphasize, so a phase 1 study, I know this very well in cancer treatment. Phase 1 study, the outcome is not actually disease. Like in cancer, a phase 1 study, the point is not actually to treat the cancer, although that's your end goal. But in a phase 1 study, it's all about safety. Okay. In a phase 2 study is when we start talking about whether that new treatment actually has a quantifiable effect on the disease. So in the setting of cancer, a phase 2 study is one where we've determined what we think is a good dose, we've defined the side effect profile, and now we're saying, okay, does it shrink that cancer in that example? So then phase 3 is a much larger study. I know you have several hundred or thousands of people in a phase 3 study. And that's where you compare head to head. So for example, if you're doing like a breast cancer treatment study, we know what we would call standard of care for breast cancer treatment. Maybe we have a new drug we want to add to that. that would be a comparison where we would have people randomly assigned to the regular standard of care treatment and then to the new treatment. It also continually monitors adverse events and collects lots of safety info. So not all the clinical trial safety info is the most important part. Phase 4 is not something you hear a whole lot about, but it's what is called aftermarket research. So drugs that have been on the market for a long, long time. Studies are always ongoing to follow patients for long-term side effects. So then these are a list of questions. Again, I'm going to share them because I don't have time to review them. But thinking about this clinical research for me, people participate for a lot of reasons. Healthy volunteers often want to help others and contribute to science. People who have an illness often want to try to get the best new treatment and also help their community. I have a list of questions to consider, really, as sort of making sure you understand some of the nuances of being in a study. Is it the right thing for me? What can I expect for outcomes? How am I going to feel? How's it going to be paid for? Will I be able to see my regular doctor? What do you expect for the study team? How are they going to answer my questions and all of those things? So that is a whirlwind of info. And again, I'm around and happy to answer questions and I'll share the slides. Thank you. Email me.